So these are a number of studies on this chart that have looked at different provider surveys to figure out have people actually prescribe PrEP, and then would they prescribe PrEP? And these surveys, as you can see, started in 2011, and they go right up to one that we conducted about 6 months ago, a national survey in the U.S. And the surveys are all convenience samples for the most part, with anywhere from 170 or so to 500, 600 providers. So they're not at all comprehensive representative samples, but there's some fairly large numbers here to get a sense of what providers are doing and thinking about PrEP. And the bottom line is that very few providers have prescribed PrEP until quite recently, but lots indicate that they would be willing to do so. So back in 2011, this was a regional survey that we did here in Boston and Massachusetts, and these are HIV providers and some generalists, and only a small percentage of people had prescribed PrEP. And if you recall the date of the iPrEP study being published in late 2010, the survey was done just about 4 months after that, so not surprising that very few people would have prescribed PrEP right out of the gate. It would really be just a few innovators. And then as you follow the timing from 2011, 12, 13, 14, you can see that more and more people were sort of engaging in PrEP prescribing. This 19% is actually probably a fluke, in that when you look closely at the study, probably a lot of the providers were confused between PEP and PrEP, because a lot of people talked about prescribing a 3-drug PrEP regimen. So I think this number is probably quite inflated. So really, if you look at the numbers here of people who had prescribed PrEP out from 2011 to 2013, they were really single digits. And then when we surveyed infectious disease and HIV specialists in the U.S. back in October, it had jumped up to about 1 in 3. So if you use your mind's eye to trace out that diffusion of innovation curve, there's a chance that among ID and HIV specialists, may be moving towards an inflection point where people are engaging in PrEP provision, which is an exciting time. And I think it reminds us we have to really support the early adopters and make them quite visible so that more people will see it's feasible and prescribe PrEP. There's a variety of numbers in terms of whether people would prescribe PrEP if they had engaged you in terms of their clinical practice. But again, the most recent estimate we have for HIV specialists in this national sample was that the majority of people would be willing to prescribe PrEP. Providers appropriately have some theoretical and practical concerns about using PrEP, and these are data from a study published in 2014. It was a survey of providers in Peru, and in fact, if you look at the theoretical and practical concerns about PrEP that these providers had, it really replicates itself. If you survey physicians in the U.S., and there was a survey done in Italy I'll talk about, really the same issues come up for providers, why they may hesitate to prescribe PrEP. So just yes. Some of the important issues, lack of formal guidelines, which since this was conducted.
Sorry.
Should I continue, Pedro?
Yeah. Can you please mute your microphones, because we are having.
How do you save this thing? I can't get this presentation.
Is that let me see.
How is it done? Yeah.
Is that better now?
Yeah, I'm muting everybody. Sorry about that. Please continue.
Okay, thank you. So The issues that were reported by the Peruvian providers really, again, are replicated in all the different cultures where providers have been surveyed to date. So the need for formal guidelines, concerns about increases in risky sexual behavior with PrEP, worrying about diverting resources in terms of HIV treatment towards PrEP, development of resistance, limited number of trials demonstrating efficacy, need for people to adhere. Providers having inexperience prescribing ART, particularly non-HIV specialists, of course, and then side effects in terms of bone density and renal function with the current PrEP regimens. So lots of concerns, and really they're all appropriate concerns, and the question is really how do we address them so that providers will feel comfortable moving forward, even though there may be some barriers. So we also have some data from other surveys in the U.S. where clinicians, even if they are willing to prescribe PrEP and they're willing to look past some of the theoretical concerns, have talked about some pragmatic barriers to actually getting the prescribing done. And those are structural barriers and other barriers that also need to be addressed if we're really going to figure out a way to disseminate PrEP more broadly. So providers in the U.S. mentioned time constraints, where people are ever more busy in terms of their clinical practices. There are concerns about whether insurers will cover the cost of PrEP, lack of patient requests for PrEP. One of the strongest motivators for providers that we've seen in a number of studies here is if patients actually ask for PrEP, providers are much more willing to engage and prescribe it. Some providers perceive that they have a limited number of people who would be eligible for PrEP in terms of the number of high-risk HIV-infected patients in their panels, and then a number of issues around clinicians being aware of PrEP and then trained to apply the guidelines that have since been made available in the U.S. So in these charts, the red areas demonstrate kind of either moderate or major barriers to prescribing. The lavender areas are minor barriers, and then the blue areas are where providers perceive no barriers. So you can see there's very little blue on the screen, and it speaks to the fact that providers who are busy with lots of other things they have to worry about may see this as a pragmatic challenge, so we need to figure out ways to support them in terms of their clinical practice. Well, a study done in Italy in terms of a survey of physicians about their willingness to prescribe PrEP that was focused on infectious disease specialists found that there were a number of concerns that were associated with a negative intention towards prescribing PrEP. And I think using studies like this to figure out ways we can inform providers and engage them and address their concerns is a very helpful approach to integrating the information about why providers are hesitant to prescribe PrEP. So, for example, in this Italian study, the factors most strongly associated with not being willing to prescribe PrEP were concerns about potential side effects, being uncomfortable prescribing unless there's clear evidence of benefit to PrEP, and then perceptions that non-biomedical prevention interventions, such as behavioral ones, would be more effective than PrEP. And finally, there were concerns that PrEP would result in less frequent HIV testing. Now, these data were gathered in 2012 and published in 2013, so there may be more comfort in terms of more PrEP efficacy studies that have been published since then. However, I do think these concerns persist among providers, particularly those who would fall into the early and late majority categories, where they may not be fully familiar with all the data, as much as, say, innovators who are involved in PrEP research or closely affiliated with institutions involved in PrEP research. So the opportunities here, I think, are we need to figure out ways to provide practitioners with safety data from randomized controlled trials that's in a digestible form, that's believable to them, that PrEP has in fact been demonstrated to be quite safe as of yet. And then providing them with succinct efficacy data summaries from the RCTs in a way that, again, is acceptable to them and digestible, may address some of their concerns about lack of evidence for benefit of PrEP and that behavioral interventions are more effective. Because in reality, the data suggests that PrEP is highly effective, even in comparison to behavioral interventions, and best when done in conjunction with behavioral interventions. So figuring out succinct ways to provide that information to clinicians can move things forward with implementing PrEP. And finally, their concern about less frequent HIV testing, I think, could be addressed by informing providers that guidelines would recommend a very intensive schedule of HIV testing for people using PrEP. For example, in the US, the recommendation is HIV testing every 2 to 3 months. So at the end of the day, I think using these studies to inform interventions can be quite helpful. The same study looked at what are the provider characteristics associated with being at increased odds of being willing to prescribe PrEP, which is also something that's important to attend to in terms of dissemination research. And the bottom line is that providers who had prescribed post-exposure prophylaxis, i.e. they had already had some comfort with HIV prevention in the biomedical realm, were the ones who are most willing to engage in PrEP provision. So for us as people may be thinking about how do we support PrEP dissemination, we can really leverage the PEP experience and any existing PEP programs to have a place where early adopters can flourish. And this is an intuitive concept. It's probably nothing surprising here to this audience, but being intentional about engaging those providers and making them quite visible if they have successes transitioning from PEP prescribing to a PEP combined with PrEP type of program can be really helpful to a larger majority of providers to see that this is doable. And finally, they found in the study people who had attended a course on PEP and PrEP were more likely to be willing to prescribe PrEP, which is not surprising at all compared to a general population of infectious disease specialists. But to me, it again speaks to really supporting early adopters, people who express an interest. We have to really help them to move their own practice forward so that they're visible to their colleagues. In the U.S., we have thought a lot about which types of providers will be best positioned to prescribe PrEP, and a couple of options have come to the forefront. So there are HIV providers or specialists, and they're going to have lots of comfort and experience prescribing antiretrovirals for either as PEP or in terms of HIV treatment. So they'd be a natural group in terms of being innovators and early adopters. But some of the HIV providers have reported they don't see very many at-risk persons. So they've sort of said, gee, maybe this isn't really something we can do a whole lot of because we don't see a lot of people who are candidates for PrEP. So then looking at primary care providers, they're going to see most of the HIV uninfected people just by sheer numbers that present to care, but they'll potentially have very limited experience with antiretroviral medications, so they're going to need more comfort and training to actually do the prescribing work in terms of providing PrEP. STD clinicians are people who will see a population enriched with risk factors for HIV acquisition, so they'd be a natural group to contact people who would be PrEP candidates. However, at least in the U.S., the infrastructure is not there in most STD clinics where people tend to come in for 1 or maybe 2 visits as opposed to the longitudinal care and monitoring that you can have in a primary care clinic or in an HIV specialty clinic. So sorting out which of these providers will be primarily responsible has been an important concept to think about. And at the end of the day, the answer is probably engaging all of the above to whatever degree is feasible will be the best approach. We've done some qualitative work with HIV specialists and primary care generalists to figure out what they would think about prescribing PrEP, and we learned some very interesting themes. So these are some quotes from an in-depth focus group we did with some specialists and generalists. And this top quote is from a person who's a generalist but also has some HIV specialty experience. And this provider said that practical issue number 1 with disseminating PrEP is that the people who are going to be prescribing these drugs in theory, who are going to be in the best position, are going to be primary care providers with little or no HIV experience. So as part of the same study, we asked a generalist who really has a little bit of HIV specialty knowledge, but essentially was a full generalist in terms of her practice. And she said, I think that the idea of adding to what I just did this morning and adding a discussion with my patients about what is their likelihood of having sexual encounters with patients who are HIV infected, and then on top of that, trying to prescribe and get approved medications like Truvada or some other pre-exposure prophylaxis, I just can't imagine it working in the hands of a primary care doctor. So from this study, we kind of realized that there was a paradox emerging that HIV providers felt that primary care providers were going to be the ones who should be primarily responsible for prescribing PrEP, but that primary care generalists really didn't feel that it would be feasible in their hands. And we coined this term a purview paradox, where no one really thought it was going to be in their purview, is a kind of a danger zone for getting PrEP disseminated. And unless it's addressed and providers can rethink their potential role in prescribing PrEP and see opportunities to engage in this, I have some concern that that tipping point approach that we really need to see for primary care providers and HIV specialists, so that the larger majority of providers will engage in this, may be at risk. So keeping in mind this purview paradox will be important moving forward. A study in the U.S. conducted by Jill Blumenthal out of San Diego looked at what were provider beliefs about the optimal site for PrEP implementation. So this was a survey that kind of tested this idea of the purview paradox. Was it real or was it imagined? And they surveyed about 250 or so providers. 120 of them were HIV providers. 109 were non-HIV providers, and they asked them what would be the best site to implement PrEP. And as you can see, the HIV providers, 39% thought that HIV providers would be the best way to implement PrEP, which means that 61% felt this was really going to be best in someone else's hands. Looking at the non-HIV providers, only 34% thought it would be best done in their hands, and again, nearly two-thirds thought it would be best in someone else's hands. So keeping in mind there's probably some evidence that this purview paradox is affecting people's self-perception about their clinical role in PrEP provision will be important as we think about engaging providers. There was a study done by Charlene Flash at Baylor in Texas that looked at U.S. retail pharmacies from 2012 till the first part of 2014, just over a year ago, to see how many PrEP prescriptions were actually being provided in the real world. And these were retail pharmacies that are not necessarily affiliated with academic centers where you would think you may have some of the innovators in terms of PrEP provision. And what they found was there were about 3,200 unique PrEP users from 2012 to the first part of 2014 in the U.S. So it's a fairly large number in one respect, in that it's several thousand people. But if you think about, in the U.S. we have 50,000 new HIV infections each year. Even if the number needed to treat with PrEP were 1, so every PrEP prescription actually prevented an infection, you would need 50,000 PrEP prescriptions to have been written to really impact the HIV epidemic in a dramatic way. So we're nowhere near that. Even if this represents about half of what's being prescribed in the country and you double that number, you're still only at a tiny fraction of the 50,000 new infections we know are occurring each year. So the bottom line from this study is, number one, we need to figure out ways to increase these numbers to get PrEP in the hands of people who are most likely to benefit from it. The study looked at which types of providers had actually provided PrEP by their specialty, and what they found was that 11% of the prescriptions were done by infectious disease specialists, and the rest of them were by a series of different forms of primary care specialties. So internal medicine physicians, family medicine providers, nurse practitioners, physician assistants, and then kind of an other where we're not really sure. Some of those are probably obstetricians and gynecologists taking care of primarily women in their practices. So to me, this suggests that both HIV specialists and infectious disease specialists are going to be important to increase their numbers, but it's encouraging to see that lots of generalists were willing to engage in PrEP provision, even though many of them may have had limited experience with antiretroviral medications prior to this. So early days in terms of disseminating PrEP in the U.S., but it's been about a year since the study was conducted, and my suspicion based on some of the other data that have come in is that we probably are seeing more PrEP prescriptions going out this year by far compared to last year. So further studies like this will be helpful going forward. We have some data looking at a national survey of infectious disease providers in the U.S. through the Infectious Disease Society of America, which is the professional body that governs these clinicians in the U.S. And we surveyed about 400 or 500 of these specialists back in October, as I had mentioned before, and we found some very encouraging data. These were data we presented at the Retroviral Conference earlier this year. So we asked providers, what do you consider part of your clinical role as an ID infectious disease specialist in terms of PrEP? And then we asked them, well, what have you actually done in your own personal practice? So looking at whether they thought counseling about PrEP was part of their role, almost all the providers felt that it was. 87% felt that it was, whereas only 59% had actually counseled their HIV-infected patients about PrEP. So these are, I think, very encouraging numbers. It would be shocking if everyone who felt like this was important had actually done it. So the fact that over 50% of providers had actually counseled an HIV-infected person that PrEP may be an option for their partners was very encouraging news, and I think this number will probably continue to grow. In terms of whether they thought they should actually offer visits in their schedules for HIV-uninfected partners of their HIV-infected patients, 71% of providers thought that they should be doing that, and 41% had done so. So again, this is not 100%, but encouraging that providers who are facing a very new concept in their practice seem to be changing towards acceptability of this new innovation. We asked them if they thought they should be prescribing PrEP, and almost 70% thought that they should be doing this, but only 32% had actually done it. So as I showed you in the slide, a couple of slides before, that 32% still represents a much larger number than any of the surveys that had been conducted in 2011, 12, and 13. So again, we may be hitting a nice inflection point where at least HIV specialists are going to be adopting this practice. We also asked these clinicians what they thought about prescribing PrEP to serodiscordant couples where the HIV-infected partner was either on antiretroviral therapy or not. And so we asked them if the HIV-infected partner in a couple was not on therapy and was viremic, would you prescribe PrEP? And 80% said that they would. So it's quite a high number. If the HIV-infected partner was on antiretroviral therapy but really had suboptimal adherence, so they at times had viremia, still 3/4 would prescribe PrEP to their partners, so also quite a high number. We asked them about whether they would prescribe PrEP if the HIV-infected partner had an undetectable viral load, and 1/3 of the providers would even provide PrEP in that context. So my takeaway here is that there's a lot of willingness to recommend PrEP to their patients, which suggests that providers are starting to see this as something that really can benefit patients, and again, quite encouraging news. We also asked providers what the typical approach to safer conception would be for serodiscordant couples in their practices, and we focused on asking them about couples where the male was HIV infected and on suppressive antiretroviral therapy and had an uninfected female partner. And we didn't ask them what they thought was the best approach, but we just asked them what tends to happen in your clinical practice to get a sense about how PrEP was fitting into the periconception ways PrEP may be applied. And 35% of the providers were unsure, which suggests that they probably hadn't had a lot of couples in their practice. Of the providers who were more sure of what was happening, 1/4 said that PrEP was being used during periods of non-condom sex. 19% said that couples were having non-condom sex without PrEP. So in this case, they're really relying on the transmission benefits of having a suppressed HIV-infected partner in couples. And 16% said that they relied on sperm processing and assisted reproduction, which is something that has a very high efficacy for preventing HIV transmission as part of conception, but of course it's not something that's available in most places, even in the US, where there tends to be lots of resources available. And in other parts of the world, it may also be challenging to find this as a resource. So taking it back to PrEP, about 1/4 of providers felt like PrEP was being used at least some of the time as part of periconception strategies. I want to focus a little bit on some of the potential pitfalls with providers and PrEP. And in the interest of time, given that we had some technical difficulties for which I apologize, I will really summarize the next couple of points so we can have some of the discussion that I know Carlos was hoping to have at the end as well. So some physicians may actually benefit from some training in numeracy, and this is not just physicians but providers in general. And numeracy is their comfort with conveying complicated numbers, and I think that's important in terms of conveying efficacy numbers for PrEP, which tends to be talked about in terms of relative risk, and both providers and patients may not know what exactly those numbers mean. And so if we want people to be making informed decisions about whether PrEP is right for them, conveying the numbers accurately will be important. So the study that looked at this was published by Matthew Mimiaga in AIDS Care a few years ago, where a number of physicians were showed a summary of the IPREC study, the study that showed that TDF-FTC pill reduced HIV infections by 44% among HIV-infected men who have sex with men who were assigned to take the active medication daily. How do you interpret these results? So it's kind of a quiz of sorts to see how people would interpret an efficacy estimate. So they were asked if it means that a man taking the pill who had sex 100 times without a condom would be protected the first 44 times. A man would be protected from HIV 44% of the time if he takes the pill daily. 1 pill a day protects against HIV 44% of the time. 2 pills protects 88% of the time. The pill may be expected to prevent 44% of the infections that would occur in a population if the pill wasn't used. And then if a man had sex while using the pill, his chances of getting HIV will be 44% less than if he hadn't been taking the pill at all. So the bottom line of this study is that 72% of just over 100 physicians who were asked about these data correctly interpreted these data, which is good that it's a majority of physicians, but it shows that there may be gaps in terms of effectively communicating all of the numerical data that comes out of the efficacy and safety related studies for PrEP. So figuring out how to train providers to communicate these effectively will be important to kind of do what's best for patients in making their decisions. There's also a potential bias that seems to be emerging from some of the literature in terms of which risk factors in terms of the patient populations would trigger PrEP candidacy in the eyes of providers. And it seems that providers may be more willing to prescribe PrEP to men who have sex with men or people in serodiscordant couples than for persons who are injecting drugs. So this was a study from Italy where they asked 174 physicians if they would prescribe PrEP to certain types of people in terms of their HIV risk factors. And you can see that 79% would prescribe PrEP to women in heterosexual couples if they were at risk. 79% would prescribe PrEP to men in MSM couples, and basically high numbers for lots of people who are MSM or serodiscordant couples or other types of sexual risk behaviors. But when asked about whether injecting drug users would be candidates for PrEP, only 21% said that they would prescribe PrEP to this population. So a big difference. In all fairness, this study was conducted before the major PrEP study showed efficacy of PrEP in preventing injection drug use transmission. That was conducted in Thailand and published just after the study was published. But if you think about some data from other studies, it looks like there may be a bias against prescribing to people who are injecting drugs as well, or at least that maybe providers aren't feeling as prepared to do so in terms of their skill and their training. So in our survey of the HIV and ID specialists in the US, we just focus on the area that's circled here. We asked providers if they thought that people who injected drugs who were HIV uninfected should be prescribed PrEP. Only 42% thought that they should be offered PrEP. And then we asked them if they felt prepared to do this, to provide PrEP to people using injection drugs, and only 26% said they felt prepared to do so. And if you recall from earlier in the talk, there was much higher numbers for people who were willing to prescribe to serodiscordant couples, up to 80% in the context of a serodiscordant couple. So I think we have to be careful to address any potential either conscious or really subconscious biases against providing PrEP to these patients, because it may impinge upon their access to needed prevention interventions. There may also be the potential for bias in terms of race, in terms of who is provided with PrEP. There was a very elegant study conducted by Sarah Calabresi and her group at Yale, where medical students at Yale, so not fully fledged physicians, but physicians in training, were provided with clinical scenarios about a patient who was a man who had sex with men, who engaged in non-condom sex, and would, by most guidelines today, be a candidate for PrEP. And what they did is they actually varied the race of the patient from black to white, and they randomized medical students to make decisions about, do you think you would prescribe PrEP to this patient when you become a physician? And they just varied the race in terms of the clinical scenario. And what they found is that the students judged the black patient as more likely to engage in sexual risk compensation if they were provided PrEP than the white patient, and these were statistically significant differences. So there seemed to be some racial bias, which is probably a subconscious bias based on the way the study was done. So presupposing that black patients would be more likely to increase their risk behaviors while using PrEP. And they also, in terms of other questions in the study, found that providers' willingness to provide PrEP was strongly related to their sexual risk compensation beliefs. So if they felt that people would take PrEP and then abandon condom use, they were much less willing to prescribe it. So at the bottom line, the study demonstrated that the students felt like if patients were black, they probably would have increased predicted sexual risk behaviors while using PrEP, and therefore the providers were less willing to prescribe PrEP. So there are a lot of caveats here. It's not a generalizable study, and there were students and not providers, but it does speak to the fact that there may be some important subconscious racial biases that could really impede access among populations who are particularly at increased risk for HIV acquisition in this country, for example. And so figuring out ways to address these biases will be important to ensure the equitable distribution of PrEP. So the last 2 points I'll make are that figuring out who may or may not benefit from PrEP, it's really going to be important for clinicians to engage in routine and non-judgmental risk assessments. And this is a cartoon that just shows a clinician talking to a patient, and the clinician says, whoa, way too much information. And it's, I think, poking fun at the fact that patients may be in a very vulnerable position when they're being interviewed by their clinicians about their sexual orientation, their sexual risk behaviors. And if we want to give patients the best quality of care, and if we want to gather the most important information about whether a person would or would not benefit from PrEP, we really have to be careful about having an open, welcoming, and non-judgmental environment. And that's a huge challenge to train clinicians in feeling more comfortable having these discussions routinely with their patients. But it's something that we need to address more broadly. There are some tools that exist to help providers assess which patients may be candidates for PrEP. And this is a risk prediction tool that the CDC has developed. And basically what that tool is it allows providers to ask patients a few basic questions about their demographics and sexual risk behaviors, and using just pen and paper, come up with a score. And if the score is above a certain threshold, clinicians should consider discussing PrEP with their patients. And for example, some of the questions are about having receptive anal sex, using crystal methamphetamine, which has been associated with increased risk behaviors, and patient's age in terms of the demographics at which HIV acquisition is most common. And so this isn't necessarily going to replace ever an informed discussion with a provider and a patient about sexual risk behaviors, but it may be a way to facilitate risk screening in large populations, particularly if providers aren't comfortable and aren't necessarily familiar with what are the indications for PrEP. Tools such as these may be helpful in terms of engaging a larger array of providers in identifying PrEP candidates. So the last slide here, I think that providers would benefit from thinking about HIV testing as what I would call a universal action item. So this is the idea that we can all hopefully agree that everyone should have an HIV test who may be at risk for HIV infection. And in the US, it's recommended that everyone from the ages of 15 to 65 have HIV screening. If someone is HIV infected, the action that you take is to link them to HIV care, which is an important topic in and of itself. But I think where we have a lot of work to do is when there's an HIV negative test that comes back, some clinicians understandably would sort of feel like, okay, we have a negative test, really nothing to do here. Whatever this person is doing to stay negative seems to be working, so let's just keep moving along the same trajectory. And I would argue that this is actually an action item where everyone with an HIV negative test should engage in a detailed risk assessment to see what is their risk for becoming infected. Just because they have it to date, of course, does not predict that they won't in the future. And so if providers are I think, trained to think an HIV test that comes back negative, you have to take the next step and conduct a risk assessment. Now, if it was done before the test, then that's great. But if it hasn't been done in an in-depth way, that's another chance to engage in a risk assessment. And that's the way you can identify people who may be candidates for PEP or PrEP. So let me end there. I was just going to summarize things, but in the interest of time, the major points I wanted to make were essentially that we are in a phase where I think we're still looking at early days for PrEP dissemination, but we may be approaching a phase where early adopters are getting engaged. And if we can support these early adopters, make their successful practices visible, then hopefully we can move towards a tipping point where a larger majority of providers are willing and engaged in providing PrEP. And there are some data, at least in HIV specialists, and also from some generalist providers in the US and in other countries, that providers are willing to do this, think it's important, and are now starting to prescribe PrEP in small numbers. So I apologize again for my role in the technical difficulties early on. I hope you were able to hear most of what I was talking about now, and I will turn the floor back over to Carlos. Thank you so much.
Thank you, Doc. I'm sorry we had that technical problem at the beginning, but I think you covered everything, and we just have a few minutes to look at the questions. So I'll go through questions and comments quickly, and if you can take notes and maybe provide a summary response to those points. There were a couple of questions about the potential role of attitudes towards pleasure and some judgmental views of PrEP as allowing for unrestrained search of pleasure among people as an obstacle for PrEP prescription, and that's probably important as well in a question that was related to attitudes towards male couples in your study. Also, one is about moralistic views. Then I guess there was a question about the role of OB/GYN, and I think you responded that probably they are providing PrEP. They are among those undefined medical specialists who provide PrEP. Then there was another question asking if there could be a concern among HIV practitioners if receiving several HIV negative people. They're worried, well, in some cases, not necessarily, but asking for PrEP prescriptions. Then another one pointing out that the HIRI scale you mentioned is more related specifically for men, and if the Denver scale that involves or applies to women would have a role to play here. And finally, a couple of comments from myself. One is that definitely your data on racial attitudes among medical students show a big barrier, because we know that in many cases African American MSM in the US would have high risk and would be more appropriate candidates for PrEP. Not because they would, and the problem wouldn't be risk compensations, because in many cases they are not using condoms, so there's nothing to compensate for. But definitely, that is something to consider. And finally, one question for outside one comment from outside the U.S. and in fact inside as well. There are many issues in PrEP prescription that need to be discussed worldwide. This is not, I mean, as health systems are so diverse in the world, so are, and even within countries, so are opportunities and settings where PrEP can be provided. In many places, HIV prevention is separate from HIV treatment and care, and in HIV prevention settings, there are no physicians. So, and the other thing is, are we talking about only about PrEP prescribed individually by a physician, or are we also talking about a more sort of general offer of PrEP, always voluntary, to people who fit the particular profile of risk? And finally, the issue of financing. So in some cases, individual prescription will imply some patient costs. When you're talking about the national program, it may be a free, out of a cost-free program. So those are questions and comments. So please, Doc.
Well, thank you, Carlos, for summarizing those. I think those are all incredibly important questions and comments, and I really agree with bringing them up and everything that you said in terms of some of the access issues and the variability by culture and geographic site. I'll try and briefly address each of the ones that I think came up, and correct me if I've missed anything. I think that physician attitudes towards sex and pleasure could certainly influence their willingness to prescribe PrEP if physicians kind of insert any kind of moralizing or judgmental approach to where they feel like they're prescribing PrEP just to let people have more pleasure and abandon condom use. Some physicians and other providers, that may affect their decision making, unfortunately. And I think, one way to potentially address that is to create an argument or an educational approach where physicians are sort of alerted to the strong impact that the fear of HIV transmission has had on, for example, male-to-male couples for many years in terms of the HIV epidemic. And there's been some very good work out of Sarit Golub's group in New York about how they've surveyed MSM patients about their concerns about becoming HIV infected, and there were striking numbers of something like 50% of patients said that they were actively worrying about becoming HIV infected during intimate romantic sexual acts. So to me, it speaks to educating people that the HIV epidemic has had a dramatic impact on the ability of many people who have been fearful of becoming HIV infected to enjoy the sort of human rights level intimacy that we all really deserve, and that PrEP can actually unlock some of those longstanding challenges. And what we've seen in actual male-male couples, for example, here in Boston, it's been a dramatic intervention. And I think reframing the potential ways that PrEP can enhance pleasure away from the idea of people being taking PrEP just so they don't have to use condoms in a way that engages a moralizing side of providers, which really I would posit doesn't have any role in our the way we care for patients, but we certainly know that it can affect people's decision making. So hopefully reframing the issue in a way that may speak to providers is one approach. The question about I see some other questions on the screen here about OBGYNs, and I think there are some OBGYNs prescribing PrEP, as you mentioned, probably in small numbers, but it's an important group to engage as well. And I think it's definitely part of the equation here, particularly as some of the studies have shown that the number of PrEP prescriptions for women versus men in the country, even though there have only been a few thousand that have been prescribed, it seems that there's a shift away from women towards men, which may be appropriate to some degree given the epidemiology in the U.S., where 2/3 of the new infections are among men who have sex with men. But we certainly don't want to ignore any of the important populations that would benefit from PrEP. There's a question here about whether HIV providers could cope with an increase in HIV negative people seeing that for PrEP, and that's a very important question too, as everyone is quite busy. And what you said, Carlos, about some places where PrEP may not be an individual physician prescribing this, but more of a programmatic approach to providing PrEP is something that certainly could be considered in terms of departments of public health or non-physician providers, where you may be able to leverage larger numbers to provide PrEP. And I think all of those models need to be maintained Were there other questions that I may have forgotten to address?
No, I think you essentially covered everything, and I guess this is. I mean, I'm just thinking we need this kind of study here in Peru and in many places in Africa, in Thailand, in Asia. We need to look at how. I mean, it's part of the demonstration studies in a way. You know how PrEP could be provided, because definitely. Because of the components it entails, the fact that it uses antiretrovirals, but it's a prevention strategy, it poses challenges to the way many things are organized. And even here, for one single country like mine, I think probably would have to think of 2 or 3 ways of providing PrEP. And the issue of individual provision versus sort of more target population programming would be important. So I'm sure the health systems component is going to be a very important focus or needs to be a very important focus around PrEP in the near future. Anyway, I think your presentation has been very thought-provoking, very interesting, and just to remind people, this has been recorded and it's going to be made available to the larger public later. And so thank you very much for having presented your data here today. And I mean, we'll be, with everybody else, we'll be having a new session. We're planning on a session on transgender issues around PrEP by the end of the month. So we're hoping to confirm that for the 30th of June, ideally. So thank you very much, Doc, and thank you all. We talk soon. Okay.
Thank you so much.
Bye-bye, Doc. Thank you so much.
Bye, thank you. So sorry about the challenges.
No worries, no worries.
Those moments are the worst moments when you just feel like, why can't it just work? And I really apologize for any stress, but I'm glad that was established.
Yeah, actually, this was a good way around, fortunately. Something that I would like to ask you, can you send me your presentation?
Algunas apreciaciones, pero cuando vi el documento...
presentation. I'm going to and then I will...
Okay.
Okay.
Bueno, pero están en todos los correos, todas las cosas. Como digo, la única persona que me hizo un